Hi, my name's Becky. I'm one of the matrons at Ipswich Hospital. This is Vicky, she's one of our senior registered nurses, and this is Stuart, one of our administrators, and we are super excited to talk to you about the Frailty assessment base at Ipswich Hospital. A little bit of a background before we go into why we have a FAB. A scene setting, so Ipswich, we have over 330,000 people. We have a high number of the older population, a longer life expectancy, a higher rate of disease prevalence. I've been struggling with that word all week. We've also had a recent change in community provider. We're working a lot more closely with our community providers, and it was a good opportunity to come up with some winter schemes and an opportunity for change. And the Frailty assessment base originally came through a pilot scheme through Sequin as one of these winter schemes. So the FAB service, everyone who comes to us has a comprehensive geriatric assessment. These are people on the cusp of an admission to hospital. They're just not quite right. There's something going on. They're older, they're frail, there's something going on. They have a multidisciplinary rapid assessment, which by our team, which Vicky will talk to you about in a second. That assessment is done within 48 hours of a referral, sometimes the same day. The referrals come to us through GPs, community teams, and through the emergency department, and all referrals go through the geriatric hotline, notice the phone, which is carried Monday to Friday. Currently, the service is open Monday to Friday, 8 till 6, and every patient who comes to us leaves us with a shared care plan. That shared care plan also goes to their GP, and it's exactly the same information that we give them, so they are fully involved from the word go.
Oh, sweet. So this is our lovely FAB clinic down the bottom. We've got rooms that go off it, and then we've got a big central bit. So quite often, if patients are waiting to see someone or waiting for blood test results, they'll come out and sit in the middle. It's quite sociable, and it's just quite nice, really, isn't it? And then this is the team, or some members of the team. Not listed on there, we also have a dietitian that will come in, and she'll come in and see them on the day, which is proved really, really, really handy. We can do referrals for anything that you would on a normal ward, so pressure relief, anything at all. We also we can do dressings. We've got dressings that we can then send home with them, so we cover all that side of everything as well, sort of included, as well as what the doctors do and the therapists do.
Excellent. The aim of the FAB team and the service we provide is to promote people living independently in their own homes or in an appropriate care setting. We really want to keep people out of hospital if we can. Before we talk about patient outcomes and patient experience, it's also important that we look at a bit of positive stakeholder feedback, particularly when you start up a pilot service. It's always quite nerve-wracking knowing what the thought is out there. But as you can see up there, the positive feedback that we have had, that's just through three of our stakeholders, 2 GPs and a consultant. And the fact that GPs didn't think they could do anything more for their patient, but we've been able to help them, I think that's quite key.
So I get to do the fun slide, the reason we're all here today, the positive patient experience. As you can see from the screen, there are a lot of our favourite compliments we've got from the patients and their families. A lot of the same words people use are the kindness, the professionalism, and the sense they're really being listened to. And as you can see from the figures, we've got 99.6% of people who recommend us to family or friends. Ever since FAB was set up, we've had a 98% of recommendation. We've never had less. Only ever had one neither likely or unlikely. We tracked them down to see why they said that, and it's because they said, why would we recommend someone to come to hospital? So I thought, I can't really argue with that, can I run after them? So that's why.
I think it's important to note that those patient experience figures there at the bottom came within the first 6 months. So the fact that we set up a pilot and were able to get such positive experience in the first 6 months meant that we got something right in the planning, and I think that was the service user involvement right from the word go. So, discharge destination, one of the things that really makes me happy about this service is most people get to go home. A chunk of those people, as you'll see, more than half, got to go home without any additional care. They did go home with support, they went home with advice, because what we do is we give patients the permission to lead their health and well-being. We give them permission to know what's right and what's wrong. Some people do go home with the crisis action team. That was another one of our winter schemes, which has now gone permanent as well, and that's about providing healthcare in the home. as an admission prevention. Some went home with community therapy, some did need stepping up to an intermediate care bed or respite, and some did need admitting to hospital. But if they needed admitting to hospital, they were front-loaded with that comprehensive geriatric assessment. That means we knew every single admission was essential, and that was what we needed to see. I would be more worried if I saw no patients admitted through this service. So admission avoidance. So in our first year, we saw 931 patients. That was in our old service. That was in our 2-bedded assessment area, 931 patients. 90% of those returned home. 3% were stepped up, as we say, to intermediate care, and 7% were admitted. As part of our sequence, we were asked to look at 7 days after their FAB assessment to see if they were admitted. We chose as a team to look at 30 days. Looking at that patient group, we wanted to see within 30 days whether they were admitted. 81% were not admitted after 31 days. That again tells me that we got something right in the planning and in what we're doing in our service. So our favourite case study is on our poster that you may have seen upstairs, but we also like these. So we had a 92-year-old gentleman named Bob. I've called him Bob because I call everyone Bob. He had Parkinson's disease, prostate cancer, ischemic heart disease, and he also had a long-term catheter. He lived in sheltered accommodation, had carers 3 times a day. He was admitted, he attended ED 5 times in the last 7 months, 2 of which resulted in admissions to hospital. And on this occasion, he was admitted to ED or attended ED, and he was transferred directly to FAB. So the team saw him in FAB. He was clinically stable, didn't need admitting. He was diagnosed and treated within the unit, seen by the therapy team. Footwear advice was given, and he was referred to community therapy. That was a big key to why he was having so many attendances. He went home with a shared care plan, and since then has had no ED attendances. We gave that man the confidence to live well in the community. Case study 2, we're going to call her Mary. She was a 90-year-old lady who came with complex medical conditions. She had some bowel surgery, and she was struggling with abdominal pain and things like that, and how to manage her bowels. She lost a lot of confidence, and the GP was contacted by the family because they really wanted her admitted to hospital. So she was referred to FAB and seen within 48 hours. We did avoid her admission. She was given reassurance, and the big thing for her was around self-management, and she was also referred for community therapy. She felt greatly reassured. She went home feeling she'd been managed well, and the GP felt this was a very successful outcome. What I haven't written on there is this family and this lady wanted her to go into a care home. She really wasn't coping at home. She didn't even leave us with a care package. She left us with the confidence to live well in the community. See the theme? So what's next for our beautiful FAB? So we have recently moved into a 6-bedded, dementia-friendly assessment area. So if we saw nearly 1,000 patients in a 2-bedded assessment area, we're going to take over the world in this bad boy. And we've plastered photographs of it all the way through here because we are so proud of how it looks. We're also doing more proactive ED finding, which means we're taking more patients straight from the emergency department. We've all heard of, I'm sure, of patients being deconditioned by being in hospital and the whole PJ paralysis. We're not even letting it get to that stage. You come through the front door, we take you straight out. And in fact, in recent weeks, we've started taking straight from paramedics. They're not even coming through the ED department. Fantastic. We're going to 7-day working. We're not quite there yet due to staffing levels mainly. We're edging towards 6-day working. We'll also be looking at implementing a telephone follow-up service just to see how patients are getting on after their visit to FAB, and further staff training. And our nurses that are working in the department now, they're looking at, they are doing modules in management of the complex patient, non-medical prescribing, etc., etc., etc. Our challenges, and we love a challenge to bring it on, is the match of capacity with the volatile demand. We're hoping the fact that we've got a bigger unit is going to help something like that. But we've talked to you about how well we've helped some of our patients. We would hate people to slip through the net, so there's work to do. And whether that's for us in-reaching to the wards or outreaching into the community, we call that FAB in a van. We'll see how that goes. But then we've also got the IT interface, and patients, I did this in my masters, and patients will often talk about this, the fact that IT systems do not talk to each other and they can't blooming stand it. I go to my GP, tell them one story. I come and see you, I tell you the same story. And we're trying to work ways, so with System 1 it is, that we can work so we use the same system, so no one is duplicating in IT systems. But as I say, that's our challenge for the next year, because we need something new to do.
We do.
And that's going to be it. Thank you very much for listening. Do you have any questions?